This is a presentation of the chapter The Neurosurgical Intensive Care Unit and the Unique Role of the Neurosurgeon. The history of the neuro-ICU goes back to Harvey Cushing. One of Harvey Cushing's seminal works provided a foundational basis for many of the principles deployed in modern neurocritical care. The piece was published in 1901 as part of the Bulletin of the Johns Hopkins Hospital and investigated the relationship of saline-induced increases in intracranial pressure with corresponding increases in arterial blood pressure, as well as partial cessation of respiration. Cushing's observations in World War I led to his staff and residents establishing early mobile units considered first dedicated neuro-ICUs. Evaluation of the neuro-ICU patient. Without question, one of the most challenging tasks for physicians in the neuro-ICU is obtaining proper serial assessments. Neurosurgical evaluation must begin early at the time of admission of a patient to the neuro-ICU, even if obtaining history and detailed exams are difficult due to endotracheal intubation or altered mental status. Begin with ABCs, and after thorough physical examination, meticulous imaging review is necessary. Proceed with careful systems-based practice for all patient transfers with proper communication and interpersonal skills between all teams regarding the patient's neurological and systemic disorders, as well as all initial interventions that have been performed outside of the neuro-ICU. The role of the ICU in the care of neurosurgery patients. Originally, the primary systems model for neuro-ICU care was a low-intensity model that involved direct management of neurosurgical patients almost exclusively by neurosurgeons, with limited consultation by other medical and surgical services. Those models later transitioned to higher intensity models with assistance and consultation from intensivists. Practice of care models were then developed in closed or semi-closed multi-system medical or surgical ICUs, where patients were directly managed by a dedicated full-time intensive care team that led the management of ICU patients for the length of their ICU stay. As medical and surgical critical care units have shown increasing specialization, the trend has also carried over to neurocritical care. This led to the development of dedicated ICUs for the management of specific neurological disorders including TBI, subarachnoid hemorrhage, and stroke. Neurosurgical intensive care is now considered a subspecialty of neurology and neurosurgery, with neurointensivists specializing in critical care and being primarily responsible for patients. More recently, the PRINCE study, a global collaboration evaluating neurocritical care practice patterns and outcomes, found that the absence of a dedicated neurocritical care unit to be an independent predictor of in-hospital mortality. There are core elements of neuro-ICU care. A particular task is monitoring for neurological decline, which is especially important in patients with TBI. ICP management is one of the paramount responsibilities in neurocritical care. Another distinctive entity requiring the neurosurgeon's understanding and skill set is the management of patients with acute aneurysmal subarachnoid hemorrhage. Evaluation of subarachnoid hemorrhage patients with confusion, stupor, or coma is challenging and may necessitate neurosurgical intervention to divert CSF for hydrocephalus and treatment to prevent aneurysm re-rupture. Furthermore, neurosurgeons must also be closely involved and familiar with management of patients following acute ischemic stroke. Whether stenting, angioplasty, or mechanical thrombectomy, neurosurgeons have continued to take an increasing role in stroke intervention. In order to ensure uniform neurocritical care training, the Society of Neurological Surgeons Committee on Advanced Subspecialty Training CAST has defined program requirements that have to be met and include clinical skills and knowledge curriculum. The duration of dedicated neurocritical care subspecialty training must be 12 months. Training must occur in a surgical critical care unit or a neurological critical care unit with exposure to both pediatric and adult patients who sustain traumatic injuries, acute cerebrovascular conditions, neuro-oncologic disorders, status epilepticus, and spine trauma and spinal cord disorders. There are 4 basic models of neurosurgical ICUs that are based on the degree of involvement of the neurosurgeon and are summarized in this table. In the traditional model, the primary responsibility lies with the rotating surgical or medical intensivist. In academic settings, this model typically exists as a closed unit with primary management of critical care issues by an intensivist. In the community setting, the open model is more common, with primary responsibility lying with the neurosurgeon, with consultation by medical or surgical intensivists. In community hospitals, a second model has evolved with the development of neurointensivists. In an open setting, neurointensivists provide consultation on matters of general and neurological critical care, while neurosurgeons primarily manage the neuro-ICU patients. A third model was developed with dedicated neurointensivists available for primary management of neuro-ICU patients. A fourth model mimics the practice of mini-surgical ICUs in some academic centers and involves management by dedicated neurosurgeons for all neuro-ICU patients. These CAST-certified neurosurgeons coordinate care and ensure direct involvement of neurosurgeons throughout the ICU stay. The most recent development is the introduction of the mobile stroke unit, which can serve as an extension of the neuro-ICU. Mobile stroke units are designed to aid in acute pre-hospital stroke management and ensure early diagnosis of an ischemic stroke and administration of TPA in the field. In conclusion, the neurosurgeon has a unique responsibility and necessary role in managing and coordinating care for patients in the neuro-ICU. Residency and fellowship training in critical care provides necessary knowledge to help manage pre-, peri-, and post-operative patients. Identifying neurologic changes or operative pathologies is paramount to improved patient care.